Okay. Okay, so I guess we'll get started. I'm Ed Levin, Director of the Center on Addiction and Behavior Change, part of DIBS, and welcome to our seminar series. This is the second seminar of the fall semester 2021. And just to look ahead a bit, next week we're going to continue on, and we're going to have Paul Meyer from the University of Buffalo in New York talk. He's actually the first in the series of 4 seminars we're going to have on the nicotine research seminar series, Interacting Brain Systems. And he'll talk about the incentive value of nicotine being amplified during operant and Pavlovian conditioning. And then that'll be followed a couple weeks later by Britta Hahn from Maryland, Edie London from UCLA, and Paul Kinney from Sinai, all talking about nicotine and tobacco and that addiction and the kind of interaction of brain systems involved with that. And then we're going to go local with Justin Sharp from Duke, as well as Connor O'Neill speaking about issues and treatments here at Duke University, and Alex Marshall from NC Central, our sister institution here in Durham, talking about his preclinical research on neuroimmune response. And actually, Emily Reisman from NC State needs to move her talk to next semester. So that actually opens up an opportunity if anyone wants to speak. There's an open slot December 1st, or we can flex it a little bit earlier if need be. Also, I'm putting together a seminar series for next semester. And so there's still some open slots there. And I just wanted to mention, as a foreshadowing, we're putting together a cannabis symposium together with TRI organization here, a community activist organization, and DIBS for this is on the 22nd of February. It's going to be a day-long symposium on community and brain health and cannabis legalization. So in any case, now I'd like to get on to introduce today's speaker. Dr. Ray Lee is professor of psychiatry and neuroscience at Yale University. He's been there for over 20 years, and he graduated from National Taiwan University College of Medicine and also the California Institute of Technology, and has been at Yale since 2003. And his research has to do with cocaine craving, and today he's going to speak to us about imaging cues, stress, and reward responses. Right?
All right. Yeah. Well, thank you very much, Dr. Levin, for inviting me, and very happy to be here to share my research. So I'm going to share the screen, the slides. So
yeah, that's fine.
So so I've been at Yale for almost 20 years now, and my lab research focus is primarily on like addiction neuroscience. So we're trying to combine experimental psychology and brain imaging to identify the circuit markers of addiction. We've been working on cocaine and alcohol addiction, and more recently trying to do a little bit on smoking. So here's a schematic of the sort of the behavioral and the psychological states of addiction that I think most of us are very familiar with. So essentially there is a stage of like drug using. And then, when you are not using drugs, you're craving for drugs. So there is a sort of a chronic cocaine and craving state. And a lot of us have been trying to understand the different the myriad of psychological processes under during this this non-drug using abstinence or craving state. So, for instance, people have hypothesized that when people are not using drugs, during the withdrawal stage, they're probably experiencing a deficiency in reward. So there's a sort of under, active reward circuits in the brain. And also, people tend to be particularly in the case of stimulants, like when you are not using, you've been using cocaine for 10, 20 years, and then, when you are not using it, you tend to experience this physical and then the mental symptoms, including like fatigue, lack of energy, lack of interest, and depression. So, depression and stress response, might be a key psychological process underlying this chronic cocaine craving. And of course, there's this drug and cue memories, because the stimulants are highly arousing and stimulating and rewarding. So the memory associated with the experience of drug use and the context of drug use, tend to be pretty strong. And some of us, think that that memory and cue processes are critical, in a transition, for people to want to get back to drug use. And also, so on top of all this, that there is there's this concept of lack of control, because, if you talk to these drug users, asking them why they continue to use drugs, none of them will tell you that, well, it's just great, right? So most of them would say that they understand the consequences of drug use, but they just couldn't help it. They can't control their behavior. And so in terms of lack of control, so we've in the past maybe 10, 15 years have spent a lot of time using the stop signal task in the imaging setting to understand the component processes of cognitive control dysfunction in cocaine and alcohol addicts. So we look at response inhibition, error processing, and post-error behavioral adjustments to see which neural circuit is more critical in terms of characterizing the differences between cocaine users and non-drug users, as well as predicting relapse in a cocaine cohort. But today, I'm going to focus on reward and stress response, and also cue response. So, so there are multiple psychological processes involved in chronic cocaine craving, but the question is still, why is this craving state important? And I think we all know that craving tend to persist long after abstinence. So for people who have been off cocaine for a year or two, sometimes they will still tell you that they can feel that like tingling when they think about using cocaine. So that really speaks to the power of the memory. So that's and that's why makes this construct pretty critical in terms of understand the pathophysiology of addiction, and also the implications for treatment and interventions. In chronic cocaine craving, there have been a lot of studies showing that chronic craving can predict relapse. So that obviously make it a candidate target to study. And as a matter of fact, a lot of clinical trials evaluate craving as a secondary or interim outcome. Okay, so and the other things that I would like to say about chronic cocaine craving is that it is related to recent cocaine use severity. It's probably, we haven't published on this yet, but we, so from data that we saw in several cohorts, we saw that the chronic cocaine craving is more related to recent cocaine use severity, and not as much to the duration, the years of cocaine use. So, overview of the studies. So we'll be talking about reward and negative motion and cue reactivity. And most of these studies are cross-sectional studies. So we haven't really had a chance to do this, look at the longitudinal data yet. So I'll be sharing the cross-sectional studies, findings from the studies today. And these studies are mostly of a moderate sample size. So we have about 50 cocaine users and 50 non-drug using controls. And these cocaine users typically have used cocaine for 10 to 20 years. So, and then the great majority of them use crack cocaine. And in terms of healthy controls, we don't just match them in age and sex composition, but also in terms of their years of drinking. Because, as you know, like most cocaine users drink alcohol. So we feel that it's pretty important to match them in the sort of the duration of, at least the duration of drinking. It's very, hard to quantify sort of the lifetime amount of alcohol use, but we do our best and using the years of drinking as a covariate. So, and then these are all inpatient studies. So we get patients, we assess and recruit patients to the CNRU, the Clinical Neuroscience Research Unit, CMC. So they stay on the unit for about 2 to 4 weeks, depending on the study. And then typically for the fMRI part, we got to scan them around like day 10. So they have been absent for at least 10 days. And we assess chronic cocaine craving using the cocaine craving questionnaire. So we do it like every other day and then, or every 3 days, if it's over a weekend. And we either, use the measure on the day of the MR scan, or we use a measure the average out of all the assessments. The results are almost identical because the CCQ score did not appear to fluctuate very much, during the 10 days or 2 weeks. And for the fMRI studies, sorry, we almost always recorded skin conductance at the same time, concurrently. So we hoping to use the skin conductance response as a measure, as a objective physiological measure of arousal, like how aroused they are during these different blocks or events in the behavioral task. And we use mostly SPM for data pre-processing and modeling. And in statistics, we typically run a one sample t-test on users and non-users and do a 2 sample t-test to compare the 2 groups. And because of our primary interest on chronic cocaine craving, so we also do whole brain regression against the CCQ score or against the SCR. It depends on, we typically do both. So today, obviously I will be showing you findings, the analysis where we see findings. And we always evaluate results with a corrected threshold. If it's not like, VOXL-Y is corrected for Bonferroni multiple comparisons, or we use a cluster threshold, a cluster corrected threshold. And then, once we had identified the neural markers, we run mediation and path analysis to understand the relationship between clinical and behavioral findings and imaging findings. These are like cross-sectional studies, so you can't really say a whole lot about these findings from path and mediation analysis, but we do it anyway because we feel that the findings do provide some insight, at least help the explanations. And the last point I would like to make is that we, during the behavioral task, we also assess this like subjective craving, meaning that, the craving, we use a Likert scale, and then, ask them to rate how craving they are, on a scale from 0 to 10. And we typically do not see a whole lot of findings on these craving ratings. But we'll see some of that later. Okay, so the first study is about reward reactivity. So that so one idea is that with during abstinence or as a result of chronic cocaine use, people have their reward circuits sort of in an under-responsive state, and perhaps because of these like under-responsive reward circuits, people crave cocaine right? And also as a result of these under-responsive reward circuits, cocaine users are not as motivated for non-drug, even including like primary reinforcers. So there is a huge literature to that. So the questions obviously are, do cocaine users do show underactivation of the reward circuit, including, for instance, the ventral striatum, and whether underactivation of the reward circuit, do support cocaine craving, right? So to address these questions, we use the monetary incentive delay task and a full Q reactivity task. So here is a schematic of the MIDT. I think, so I'm just going to go through the task a little bit. So there are many trials, and at the beginning of trials, people are shown a reward queue. So either a small reward, a cent, or a 1 cent, or like a big reward, $1, or no reward. And the subjects are instructed to, so after a randomized interval between 1 to 5 seconds, people are shown a treasure box, that's kind of the go signal. And they're instructed to press button to collect money in the treasure box, as quickly as possible. And after they do that, they are shown a feedback signal. Either they, made it or they didn't. But what we did slightly different here in this variant of MIDT is that we use a staircase procedure to titrate the difficulty to change the reaction time window, because they do have to respond within the reaction time window to successfully collect the money. So we use a staircase procedure for each of the reward trials. 1 cent, $1, and no reward. So if they, let's say, successfully collect $1 in the next dollar trials, we're going to make the reaction time window a little shorter, making it more difficult for them to win again. And conversely, if they fail in the next dollar trial, we're going to make the reaction time window a little longer. And the purpose of doing this is that, first we can control the overall amount of wins. So the target is about like 67%, about 2/3 of the trials, they succeed in collecting the money. And then, by doing that, we can control for sort of the overall motivational state. It's not like, otherwise you're going to see, some people who are winning a lot of money, some people who are winning nothing, right? So there is so that's a huge kind of state variable that you need to control for. And secondly, by doing this, so we'll be able to see some like loss trials, so we can look at responses to losses. So the Panel B shows the accuracy rate for cocaine users and healthy controls across the 3 different trial types. And as you can see here that for the dollar trials, like both healthies and cocaines are successful in collecting money in approximately 65% of trials. That suggests that the staircase procedure is working well. And then also cocaine users show a higher accuracy rate, significantly higher accuracy rate than non-drug users, suggesting they're probably more like, motivated, to win money. And you can also see that in the reaction time profiles, for the dollar trials, there's no difference between groups, but for cent trials and NEO trials, for some reasons, cocaine users are, they're still more motivated to, to do that. So these are the behavioral data from the MIDT. And one finding that I would like to mention here is that when you look at the reaction time, you see a correlation, a negative correlation between CCQ score and the dollar win trial reaction time, meaning that, if it show higher chronic cocaine craving, they tend to be speedier in their response to collect that $1. So, and for brain imaging, apologize for the slide, is pretty complicated, but basically we show the whole brain map of activations for these different contrasts. And the top 3 rows are from healthy controls, and the bottom 3 are for the drug users. So if we just look at the one contrast, dollar win between versus nil. So you can see that in healthy controls, there's a lot of responses in the very robust responses in the striatum, right? And also a little bit in the medial prefrontal cortex, right? And if you look at this row of cocaine users, you also see quite a bit of response in the ventral striatum. But it's not exactly the same pattern. But you do see pretty robust response in the striatum, even in cocaine users, when they win $1 versus when they're not winning anything, right? And this shows the responses to loss in the same format. So, and again, if we just look at the top row, so when in healthy subjects, when they lose $1, they're not fast enough in pressing button, and they lost that $1. You see very robust activations in bilateral anterior insula. And you actually see exactly the same thing in chronic cocaine users. So when we run a 2-sample t-test, with all the covariates to compare drug users and healthy controls, we did not see any differences in regional responses, for any contrast, in the whole brain analysis. And because of our primary focus on the reward circuitry, obviously we run a ROI analysis to look at if the response in the striatum and it was different between users and non-users. And again, we did not see any differences, even with ROI analysis, like small volume corrections. Okay, so and then. As I said, we typically run a regression, here against the CCQ score to look at the neural correlates in the MIDT of chronic cocaine craving, right? And we do this for all of the contrasts. But for now, we'll just focus on the first row and the contrast between dollar, win, and nil. Right? So these the warm color clusters basically show the regions in positive correlation with CCQ score, right? So we see that the people who are higher in craving will show higher responses in the bilateral anterior insula when they, and also a little bit of the orbital part of the inferior frontal cortex when they, when they respond to $1 win versus nil. Okay, and in addition to anterior insula, you see the same thing. You see clusters in the precentral gyrus as well as in the SMA. Okay, so for these clusters, we run this mediation analysis. We tested like all models, even though some models are not like conceptually valid. For instance. Yeah, so you would not expect, for instance, the activations in the precentral gyrus to be preceding the like craving, right? But we tested all models because we knew reviewers would ask that question, so we typically tested all models. So for the regions that we identify from the regressions, we did this, and only the precentral gyrus show a significant mediation in their relationship, in its relationship with the days of cocaine use in a prior month, and also the CCQ score. And so basically the CCQ score completely mediates the relationship between days of cocaine use in a prior month and the activation, the effect size of the activations of the precentral gyrus during dollar win versus nil. Okay. So, and then, early on, when we look at the behavioral data, we saw a correlation between CCQ score and the reaction time, right? So if people show in higher craving, they tend to be speedier in the response to win the dollar, right? So we thought, we see a role of the precentral gyrus of the motor cortex here. And, obviously, it's very logical to test if this relationship with the reaction time can be tied together in a path model. So we tested two models, and indeed the model that's showing an effect of the motor cortical activation on reaction time shows a significant fit, right? So that kind of sort of make the interpretation easier, considering all the clinical and behavioral and imaging findings. So to conclude, so from MITT, we did not see a differences in the striatum in terms of reward activity between drug users and healthy controls, and also the striatal reactivity did not appear to be correlated significantly with CCQ scores in drug users. But we saw activations in the motor cortex that's correlated with the chronic cocaine craving and also reaction time. So we thought that probably suggests that the motor cortex partakes in the cognitive motor processes critical to drug-seeking behavior. Okay, and we would like to emphasize that the motor cortex do receive very heavy dopaminergic innervations. So these findings, even though we do not see findings in the striatum, it does not really negate the role of the dopaminergic circuits in cocaine addiction. Okay, so one caveat here is that in MITT, money is the primary reinforcer, but we use money as a reinforcer, right? But it's possible that for cocaine users, money is basically, equal to drug, so we may have to use an alternative reward, and for instance, Amazon gift card to see if indeed, they are equally motivated to win a form of reward other than money or drug. So in the second set of experiments, in the second set of experiments, sorry, I will be talking about food and drug cue reactivity. So we run these two sets of experiments together in the same cohort of subjects. So there's a literature showing that cocaine and other psychostimulants are like powerful appetite suppressants. And also there have been like observations showing that chronic cocaine users, they tend to be like, like thinner, they have less body weight. Right. However, there are also some reports showing that like cocaine addicted men, they tend to consume more high fat and high carbohydrate food. And more importantly, they actually show a decrease in the plasma levels of leptin, right? Suggesting is that they're not really, not like hungry. They're not really like, not motivated for food. So is it possible that they're not really like, the reward circuit is really not like down-regulated. They're not like under-responsive to primary reward. So to address these questions, we use the full cue craving task, And as I said, we also did experiments on cocaine cues. So there will be a cocaine cue a cocaine cue blocks. So in these experiments, so there's a fixation period, and after that, they're shown like 6 pictures of food cues, food images or drug images, each for 6 seconds. So there's 36 seconds, during the exposure block, and then towards the end, they're given 6 seconds to rate, how much they crave cocaine on a scale from 0 to 10. And before we run these experiments, they had a light supper the previous evening, and they do not have breakfast. And we always did the scans around noon, or 1 o'clock in the afternoon. So I want to show you some data on the skin conductance response. So so we basically plotted the skin conductance with the time 0, the beginning of the block as the baseline. And you can see and hear that the top 2 rows are, the top 2 panels are skin conductance response during the food craving task, and the bottom 2 are during the drug and alcohol craving task. So, as I said, we always use drinkers as controls for cocaine users. So for these healthy controls, we use alcohol cues as a surrogate of drug cues. And you can see that the skin conductors responses are typically very noisy, particularly in cocaine users. And here, as a matter of fact, for food cue, we don't really see significant differences between users and non-users, in terms of their response to food versus neutral images. And for the drug and alcohol block, I think, we see a difference during the last 12 seconds of the drug and alcohol block, but overall, we did not see a huge difference. We see a difference either. So, we'll come back to this later. So in terms of imaging, so in a 1 sample t-test, we look at the response to drug and versus neutral cues, and response to food versus neutral cues in cocaine users. And as you can see here, that cocaine users show overall, more cortical responses to drug versus neutral cues as compared to food versus neutral cues. So it looks like, drug cues, even though they do not show differences in the skin conductance responses, but from imaging you can see that drug cues appear to be more salient than food cues for cocaine users. So when you look at the food cue responses, food cue responses in healthy controls, you see. You can also tell that the cocaine users do indeed show they're less responsive to food cues than to neutral cues in comparison to healthy controls, right? So, and then when you actually run a pair sample t-test or a 2 sample t-test, you see some differences in regional activations. But again, we did not see any activity in the striatum, including the ventral striatums. So here, the cluster here, it's actually the hypothalamus. So we see a differences in higher cocaine responses in hypothalamus, visual cortex, and also the inferior parietal cortex in cocaine users. And when we do a two-sample t-test comparing full Q responses in cocaine users and healthy controls, again, we see a cluster in the hypothalamus. Right, so it looks like the the hypothalamus is probably doing something pretty unique here. So we looked at so we run the correlations and show that the hypothalamic response are in cocaine users are indeed correlated with the CCQ score and days of cocaine use. So we run a mediation analysis and show that the hypothalamic responses both during cocaine versus neutral cues and during food versus neutral cues completely mediates the relationship between CCQ score and days of cocaine use. Okay, so that again suggests basically sort of clarifies the roles of the hypothalamic response to these food or drug cues in terms of how they relate to these clinical characteristics. Yeah. So I would like to note that we did not see differences in hypothalamic response to monetary wins in MIDT between groups. So the hypothalamic response probably something like unique to food and drug cue stimulation. So for these tasks, we can conclude that the drug users, cocaine users, and healthy controls, they do not show ventral differences, ventral striatal responses to drug or food cues, and cocaine users show higher hypothalamic responses to drug versus food cues, and these the higher activations actually mediated the correlation between days of use and chronic cocaine craving. Okay, so the hypothalamus, we know that also receives very heavy dopaminergic and noradrenergic stimulations inputs, from the midbrain. Right, so the roles of dopaminergic and noradrenergic circuits in hypothalamic dysfunction in cocaine addiction, remain to be clarified, and we're going to have the last experiment. We try to say do something to address this particular issue. And in the third experiments, we look at emotion and stress reactivity. And this is, again, it is a block design. It's following the almost exactly the identical procedures. Following the 2-second fixations, subjects are presented with these images. And they are, at the end of the 36 seconds, they have 6 seconds to rate their subjective cocaine cravings. So these pictures are all selected from the IAPS. So the negative images show like lower valence, but higher arousal compared to positive images. So in this particular task, the negative emotion reactivity task, we do see that the cocaine users reported higher subjective cocaine craving during negative emotional as compared to neutral blocks. Okay. Whereas the healthy controls, the drinker controls, reported no differences between the two blocks. So it appears that these negative emotions are, compared to drug cues or food cues, are more, let's say, robust in terms of illicit physiological arousal. So here is the skin conductance data shown for cocaine users in panel A, and on the right for healthy non-drug users. And you can see that so you can see that so sorry. So I think So they reported higher subjective craving to drug versus neutral cues. But when you look at the physiological responses, they're actually they're not showing higher skin conductance response during drug trials, during this exposure to these drug images compared to neutral images. Okay, but the healthy controls, the negative emotional images, but the healthy controls do show a difference, right? So again, the data is very noisy, but when you compute the differences between these negative emotion and neutral trials, you can and look at the differences between cocaine users and healthy controls. You can see that cocaine users they do not respond like physiologically as strongly as the healthy subjects when they're exposed to these negative emotional images. However, if we take the differences between negative emotion and neutral blocks, take the difference in skin conductance response, and you do a regression against the CCQ score, you can see a positive correlation. Okay, so even though overall cocaine users were not showing as much like physiological response, skin conductance response to negative emotional images, the difference is still, correlated with chronic cocaine craving. Okay, and in this case, as a matter of fact, it's also related to the craving rating, during fMRI. Okay, so we again do a one sample t-test comparing responses to negative emotion versus neutral images, and you can see that both cocaine users and healthy controls show very robust visual cortical responses, but there are also like some differences. Healthy controls show more deactivations in the precuneus and the posterior cingulate, whereas the cocaine users show high activations in hippocampus and even a little bit of the amygdala. So when you do when we run a two sample t-test comparing the two groups, these are the three areas showing significant difference in activations, at that corrected threshold. So there is caudate, there is the inferior posterior gyrus, and also there is hippocampus. And the histogram is basically just showing, we extracted the beta estimates and show to visualize the differences. and the right panels basically show that these beta estimates in cocaine users are strongly correlated with CCQ score and also the CSSA score, this selective addiction severity score, and also days of cocaine use. And this is not, exactly surprising because these clinical measures are typically highly correlated, right? So we see this for caudate and the inferior parietal gyrus, but not so much for the hippocampus. Okay, so if you look at the hippocampus, the hippocampal activations to negative emotional images are not correlated with these clinical measures. And when we do a regression against here, we did the regression against CCQ score, and I think we didn't see very much. But when we run a regression against the differences in physiological arousal between negative emotion and neutral images, we see very robust activations in the mid, in the posterior segments of the mid-cingulate gyrus, and also the hippocampus, in correlation with the CCQ score. Okay, in correlation with the CCQ score. I'm sorry, in correlation with the skin conductance response. Okay, but because the hippocampal activations were not like correlated with CCQ score, so what exactly the hippocampus is doing during exposure to negative emotional images, we're going to have to study that more. But in terms of the mid-cingulate gyrus, we can run a mediation analysis to show that the mid-cingulate response is completely mediates the correlation between CCQ score and the skin conductance response. And we can actually, because of the correlation with the subjective craving rating, we can actually run a path analysis and, again, to better describe the relationship between the mid-cingulate response and these clinical and physiological measures. So to conclude of the emotion and stress cue task, cocaine users show higher activations in the hippocampus, inferior parietal gyrus, and caudate in response to negative emotions. And cocaine users show diminished skin conductance response to negative emotions compared to healthy non-drug users. However, the difference was positively correlated with CCQ score and craving ratings. So here I would like to say something about what we think why cocaine users are not, they don't show very good skin conductance responses, even though it suggests that these responses can potentially be an index of physiological arousal and cocaine craving. And I think that's because cocaine is a sympathomimetic, right? So, so that so if you like at ER emergency room, you see like 30-year-old with a heart attack, you need to suspect that it's probably a result of the cocaine toxicity, cardiac toxicity, right? So, because cocaine is a very powerful sympathomimetic, and skin conductance, is basically manifested as a result of the action of the sweat gland, right? And the sweat glands are innervated by the sympathetic system. It's very likely that because of the chronic exposure to cocaine, they just don't show, that strong a response to, in terms of the skin conductance to these highly salient images. And then in imaging, we show this area in mid-cingulate cortex that apparently it's mediating the chronic cocaine craving and physiological arousal elicited by drug use. That suggests that this area, which is pretty interesting because the mid-cingulate is a crucial hub of limbic motor circuits. So this area probably is pretty important in translating chronic cocaine craving into physiological responses that we think that may precipitate cocaine seeking. Okay. So in the last set of experiments, we try to distinguish the role of noradrenergic and dopaminergic dysfunctions in cocaine addictions. We know that cocaine is a very powerful inhibitor of both dopamine transporter and noradrenergic transporter. Even though the most of the studies have focused on dopamine system as part of the pathophysiology of cocaine addiction, there have been a lot of animal studies implicating the noradrenergic circuits, right? So we thought that it is pretty important to look at this, and also because the noradrenergic system is known to support arousal. Right, so it's probably this particular circuit is probably playing some role in inducing cocaine craving and drug cue elicited brain responses. Right. right? So how do we look at the noradrenergic and dopaminergic circuits, right? So one idea is to figure out whether let's say whether there are any differences in the brain regions that are that receive inputs or like functional connected, with the midbrain projection nuclei, the locus ceruleus, for the noradrenergic circuits, and the ventral tegmental area for the dopaminergic circuits, right? So we a while back we published a paper on the whole brain functional connectivity of the locus ceruleus and the ventral tegmental area, and we did see some differences in terms of how these regions respond differently, functionally connected in different ways to the LC and the VTA. However, there are also a lot of brain regions showing connectivity. They're highly correlated. In other words, there are brain regions showing that they share functional connectivity with the locus ceruleus and the ventral tegmental area. So by just like inspecting the whole brain activations, it's probably not, would not be a fruitful approach to address this issue, to distinguish the contribution of noradrenergic versus dopaminergic circuits to cocaine craving. So we thought that we might as well directly image the locus ceruleus and the ventral tegmental area, and I think it's that the like in research in Parkinson's disease and Alzheimer's disease, in these like neurodegenerative conditions, people have been using neural memory imaging to visualize and to quantify the integrity of the locus ceruleus, and certainly the ventral tegmental area. The VTA is a much larger structure than the locus ceruleus, right? So we thought that we would just, combine neural memory imaging with functional brain imaging in the same subjects, during the same setting, so we can directly visualize the spatial extent, to quantify the spatial extent of the locus ceruleus, and at the same time we can actually quantify the functional integrity of the locus ceruleus and the ventral tegmental area. So here are images that we of the brainstem, of the midbrain, that show that the locus ceruleus can indeed be visualized by this particular MR sequence for neural memory imaging. So neural memory imaging is basically it is a protein that would help that will bind to these like neurotoxic substances, including heavy metals, and because of the binding of the iron and cadmium, and it would actually show a high contrast, under this particular MR sequence. And when you look at the heat maps, you can clearly visualize the location of the locus ceruleus. Even you can see that in these whole brain sections, the locus ceruleus is really tiny. It only comprises like a few voxels, and it's located longitudinally along the fourth ventricle. So it's you do need this particular imaging sequence to be able to quantify the spatial extent and to study the function of the locus ceruleus. So we do that, and we also quantify the neuromelanin signal intensity of the locus ceruleus of the VTA. I won't go into the, this is like published in the Neuropsychopharm, and so I won't go into the procedures, but basically we identify the voxel, the coordinates of the voxel with peak intensity, and we basically just set up a few different thresholds, and to look at the entire to look at the signal intensity over various extents of the locus ceruleus to make sure that the robust the results are robust. So when you do this and you quantify the intensity of the neuromelanin signal intensity of locus coeruleus and compare them to healthy controls, you see that the signal intensity is higher in cocaine users in the LC, as compared to healthy controls. But, it's also higher in the VTA, but the difference does not reach significance. So this basically suggests that probably because of the neurotoxic effects of cocaine, because of the chronic exposure to cocaine, the LC is showing higher intensity in cocaine users. But more importantly, because we're able to quantify the spatial extent of LC, so here, sorry, I show you that. So here that we run neuromelanin imaging, but we also run the Q activation task, right? So this is what you saw previously, even though this is, I think, this is a slightly larger cohort. So you see activations during Q exposures, but there's one area that show the opposite, and that's the parohippocampal gyrus during Q exposures. During Q exposures, and more importantly, so if you identify these individual clusters that show higher activations during Q exposure in cocaine users, right? And then you run a correlation of the extent of activity, the beta estimate, with the chronic cocaine, cocaine craving score, you see a positive activations only of the parohippocampal gyrus, only of this cluster, either bilaterally or when you look at the that area, like on the right or left, particular the left, it shows a positive correlations. So in other words, even though the parohippocampal gyrus show less activations during cocaine Q versus neutral Qs, the less you see the diminution of the activity during exposure to drug Qs, the higher the subject's chronic cocaine cravings are, right? And most importantly, you can use the parohippocampal gyrus as a seed, and you run a functional connectivity analysis, right? And see if whether these parohippocampal activity is connected, it's supported by the locus coeruleus or the ventral tegmental area, right? And so that's kind of a way to distinguish the contribution of the noradrenergic versus the dopaminergic circuits. So when you do that, you run a GPPI analysis, you see the functional connectivity with the locus coeruleus, but not with the ventral tegmental area, is positively correlated with the CCQ score. So we think at least during the Q exposure, during the sort of the contextual, priming, the noradrenergic system probably plays a more important role than the dopaminergic system in terms of supporting Q evoked cocaine craving. Okay, so we are in a process of sort of extend this analysis to other paradigms, and hopefully, we'll have results to share with people soon. Okay, so to summarize about the noradrenergic circuit dysfunction and Q activities, we see deactivations of bilateral hippocampi, and also activations of a number of other structures during Q exposures. Less deactivations of the parohippocampal gyrus is associated with a higher chronic cocaine craving, and also the functional connectivity of the perihippocampal gyrus with the locus ceruleus is highly correlated with chronic cocaine craving, but not the connectivity with the ventral tegmental area. Okay, so there's this finding on the effects of chronic cocaine exposure on the neurotoxicity on the locus ceruleus systems. So we are actually for one of the studies that we're doing now, we're actually collecting data from older cocaine users to see if chronic cocaine exposures would actually accelerate the aging process, and whether that process is manifested in the locus ceruleus in this noradrenergic circuit. Okay, so just to conclude, so we show that the cocaine addiction does not appear to be associated with hypofunctions with the canonical reward circuit, with the ventral striatum. But, we use the MIDT and the full Q task, and really neither represents a primary reinforcer. Right. So really the hypothesis of under-responsive reward circuit, needs to be tested directly with the primary reinforcer. And we're just in the process of setting up experiment with Dana Small's lab at Yale, to do this. It's going to be a very difficult experiments because you have to administer like drinks or directly to see how the circuit responds to primary reinforcers, and also we show that the noradrenergic dysfunction likely plays a role in supporting chronic cravings, and we are running the same analysis across other paradigms to see how generalizable this finding is, right? And then so this I did not show you finding. So we see that the drug use apparently is pretty powerful in elicit a negative emotional state. Sorry, I didn't show you the data, so we should not talk about this. So that's it. So this is a picture we took like a couple of years ago of the people in the lab. So the study is primarily done by Dr. Shen Zhang and Simon Zolnitsky, and also Wu Yuan. This findings that are presented today. And our work is supported by the NIDA and IEEE and IMH and NIA. Yeah, thank you very much.
Oh, thank you, Dr. Lee. That was a really very comprehensive and very interesting study. So we're actually over time now, so we don't have time for discussion, but is it okay with your people contact you by email?
Sure, yeah. I'm sorry, I lost track. I didn't
oh, that's fine. You had a lot of data to present. So that was very interesting and quite relevant for understanding cocaine addiction. So thank you very much for your presentation. So I wanted to remind people next week at this time, we'll hear from Paul Meyer from University of Buffalo on nicotine amplification of incentive value during operant and Pavlovian conditioning. Okay, thank you.
Yeah, thank you.
Yeah.
Nice to meet you.